Autoimmune disorder characterized by infiltrative orbitopathy. Thyroid eye disease. Autoimmune disorder characterized by infiltrative orbitopathy. Graves' disease. Graves' disease is the most common thyroid abnormality associated with thyroid orbitopathy, but other disorders of the thyroid can have similar ocular manifestations. These include Hashimoto's thyroiditis, thyroid carcinoma, primary hyperthyroidism, and neck irradiation. Approximately 40% of patients with Graves' disease have or will develop thyroid orbitopathy. Thyroid eye disease. Associated with normal to abnormal thyroid function which may coexist, precede or follow the orbitopathy. Related to but not the same as Graves' ophthalmopathy, GO, the natural history was described by Rundle and Wilson in 1945. Thyroid status. Of those patients with thyroid orbitopathy, approximately 80% are clinically hyperthyroid and 20% are clinically euthyroid. For most patients with euthyroid Graves' orbitopathy, however, have some detectable laboratory evidence of subclinical hyperthyroidism. Both hyperthyroid and euthyroid patients can develop clinical signs and symptoms of thyroid orbitopathy. In general, patients with euthyroid Graves' disease tend to have less severe orbitopathy. Thyroid eye disease. The goal is to identify and treat patients who are at particular risk of sight-threatening complications. The disease has a finite period of activity until it becomes burnt out. The yellow region shows the early phase where there is the best response to treatment. Type 1 younger age group, wider eyes with proptosis. Inflammation is mostly in orbital fat, not muscles. Type 11 older patient with red eyes, severe sight-threatening disease, tobacco addiction is frequent. General considerations. Severe exophthalmos and compressive optic neuropathy are slightly more common in older men. There appears to be an increased prevalence of thyroid disease in smokers, for whom the relative risk of developing Graves' orbitopathy is twice as high as it is for non-smokers. The reason for this difference is not known, but one possibility is that the decreased immunosuppression in smokers may allow greater expression of autoimmune processes. Pathogenesis. Type 2 reaction. Autoimmune antibodies target somatic tissues such as extraocular muscles, causing an antigen-antibody reaction. A large number of lymphokines are implicated in the inflammatory process. Inflammation results in production of mucopolysaccharides by fibroblasts, leading to swelling followed by collagen production resulting in restriction. There is a high concentration of macrophages in the inferior rectus muscle as well as CD4+ memory T cells and CD8 T cells. This may account for the clinical observation of maximal disease activity in this muscle. Etiology. In 1956, Adams and Purvis isolated a factor in the serum of patients with Graves' hyperthyroidism that caused stimulation of the animal thyroid gland. This factor was very similar to TSH but had a longer half-life. It was therefore called long-acting thyroid stimulator, LATS. In 1964, Criss and colleagues showed that LATS had the structure of an immunoglobulin and its action could be neutralized by thyroid tissue, indicating that it was an antibody. Further experiments showed that the antibody was directed against the receptor for TSH on the follicular cell of the thyroid gland. Thyrotropin receptor antibodies, TRAB. Antibodies were originally classified into those with stimulatory properties called thyroid-stimulating immunoglobulin or antibody, TSI, ZOB, and those with inhibitory properties called TSH-binding inhibiting immunoglobulin or antibody, TBI, TBIA. Both of these groups are now referred to as thyrotropin receptor antibodies, TRAB. Physiology: hypothalamus TRH, pituitary TSH, thyroid T3 and T4. 85% of T4 converted to T3 in tissues. T3 has 5 times the activity of T4. Pathology. The predominant orbital pathology is inflammation of the orbital soft tissues and extraocular muscles. This immune-mediated inflammation consists mostly of lymphocytes and plasma cells, with a scattering of mast cells. These inflammatory changes differ from the more exuberant lymphocytic infiltration of the orbital fat and muscles, including their tendinous insertions seen in orbital pseudotumor. Pathology. The earliest change in extraocular muscles appears to be inflammation of the endomysial connective tissues, which stimulates endomysial fibroblasts to produce first hyaluronic acid and then collagen. In the acute stage there is inflammation, edema, and deposition of glycosaminoglycans. Eventually there is tethering of orbital tissues due to fibroblast proliferation. Clinical orbitopathy in general is worst in the older age groups. Lid retraction 1. Sympathetic overactivity 2. Infiltration of levator, SR complex 3. Hypotropia, retraction disappears on down gaze. Signs: Dalrymples, lid retraction, von Grief, lid lag, Kocher's, staring appearance. Infiltration. 1. Soft tissue involvement, chemosis, conjunctival injection over the recti insertions, puffy lids. Superior limbic keratoconjunctivitis, SLK, due to redundant conjunctiva. 2. Muscle involvement, diplopia due to restriction. Order of involvement IR, Mr., SR, LR. Braley's sign equals increased IOP on up gaze, greater than 4 mm of mercury. 3. Proptosis, TED is the commonest cause of unilateral or bilateral proptosis. Sight-threatening complications. Optic nerve compression, less than 5% affected, due to compression of orbital apex by enlarged EM. Look for decreased VA, color vision defects, arcuate or central scothomata, swollen optic disc. Confirmation by orbital CT. Treatment by medical or surgical decompression. Corneal exposure, potentially serious, treat with lubricants, lid taping, tarsorrhaphy, decompression. Less common causes of visual loss, glaucoma, vascular compression. Corneal involvement. Corneal involvement due to exposure keratitis may result from proptosis, upper eyelid retraction, lower eyelid retraction, leg ophthalmos, or a combination of these. A primary lacrimal gland dysfunction may also be present in Graves' orbitopathy. Although still speculative, there is some evidence of a change in the protein composition of tears in patients with thyroid orbitopathy. This change might be caused by an altered rate of tear production or by a general change in tear composition. Clinical assessment. Moritz classification indicates position on Rundle's curve. The score reduces as inflammation decreases. Parameters of disease activity, integrated severity score of Graves' ophthalmopathy, GO. Oppressive feeling pain on deviation from primary position, redness of lids, E. Recent inflammation, diffuse redness of conjunctiva, chemosis, swollen caruncle, edema of eyelids, proptosis, increase of 2 mm or more. Werner's classification indicates the damage level, so the score may not reverse as activity diminishes. 0 nil, no symptoms or signs. 1 only signs of A. Stare B. Lid lag, 2. Soft tissue involvement, 0, absent A, minimal B, moderate C, marked. 3 Proptosis of 3 mm or more, 0, absent A, 3 to 4 mm B, 5 to 7 mm C, 8 or more M.4 Diplopia, 0, absent A, limitation at extremes of gaze B, evident restriction of motion C, fixation of globe. 5 Corneal involvement, 0, absent A, SVEB, corneal ulceration, C, necrosis or perforation. 6 Sight loss, due to optic nerve, 0, absent A, 2020 to 2060 B, 2070 to 2200 C, worse than 2200. Thyroid eye disease. Lid retraction 1. Sympathetic overactivity, infiltration of levator, SR complex. Hypotropia, retraction disappears on down gaze. Signs: Dalrymples, lid retraction, von Grief, lid lag, Coker's, staring appearance. Thyroid eye disease infiltration. 1. Soft tissue involvement, chemosis, conjunctival injection over the recti, insertions, puffy lids. Thyroid eye disease. Superior limbic keratoconjunctivitis, SLK. Optic neuropathy with visual loss. The prevalence of optic neuropathy with visual loss in patients with thyroid orbitopathy is less than 5%. Optic neuropathy is, however, the most common cause of blindness secondary to thyroid orbitopathy. Its onset is often insidious and may be masked by other symptoms. These patients are usually older, age 50 to 70, are more frequently male, have a later onset of thyroid disease, and more often have diabetes. Optic neuropathy is usually bilateral, but up to 1/3 of cases may be unilateral. Optic neuropathy. Although a history of decreased vision should be carefully sought, it is important to realize that optic neuropathy can occur in a significant number, 18%, of patients with visual acuities in the range of 20/20 to 20/25, 6/6 to 6/7.5. An afferent pupillary defect is present in 35%. An abnormal disc, either swollen or pale, is seen in only 52%. Visual field defects are present in 66%. Other tests that can be useful include color vision testing and visual evoked potentials, VEPs. The Farnsworth-Munsell 100 hue test is a sensitive indicator of optic nerve dysfunction, but pseudo-isochromatic screening procedures, for example, Ishihara plates, rarely identify an acquired color defect unless optic neuropathy is severe. The pattern reversal VEP is very sensitive at detecting early optic neuropathy and may be a useful means of following patients after treatment. Intraocular pressure. The increased intraocular pressure measured during upgaze in patients with thyroid orbitopathy has been a controversial finding. When restriction of the inferior rectus muscle occurs, the intraocular pressure may increase by 6 mm Hg or more in upgaze as compared with primary gaze. The increased intraocular pressure in upgaze is a normal phenomenon exaggerated by thyroid orbitopathy. In patients with severe infiltrative disease, there is an increased pressure on upgaze as compared with normal controls and patients with mild disease. It is often not an indicator of early disease because it occurs infrequently in patients with minimal eye findings. Investigation. Serological T3, hyperthyroid T4 TSH, hypothyroid TSI, thyroid stimulating immunoglobulin. Radiological tests: orbital CT, enlarged muscle belly, tendon normal. Coca-Cola bottle sign equals muscle swelling deforming ethmoidal bones. MRI T2 showing edema of muscles. Repeating the scan in different positions of gaze can create a pseudo video of eye movements, for assessment of muscle restriction. Radioisotope tests: octreoscan, quantitative uptake of radio-labeled octreotide, which is a somatostatin analog. Visual field. A visual field should be performed in all patients suspected to have optic neuropathy and is useful when following patients after initiation of treatment. Characteristically, a central scotoma or an inferior altitudinal defect is seen in cases of compressive optic neuropathy. Other visual field defects include an enlarged blind spot, paracentral scotoma, nerve fiber bundle defect, or generalized constriction. Ultrasonography. Ultrasonography can be useful to detect early thyroid disease in patients with equivocal laboratory tests. Most patients with Graves' disease, even those without overt eye findings, have ultrasonographic evidence of extraocular muscle involvement. 46 Ultrasonography is believed by some to be more accurate than CT in detecting enlargement of the extraocular muscles. Also, visualization of the tendinous insertions onto the globe may be more accurately assessed using ultrasonography when differentiating enlarged extraocular muscles secondary to myositis from hyperthyroid orbitopathy. Ultrasonography is, however, less suited than CT to assessing muscle thickness at the orbital apex. This test may also be helpful in distinguishing between active and inactive disease. Examination of the extraocular muscles shows that there is a lower internal reflectivity in active as compared with inactive disease. CT findings in thyroid orbitopathy. The most characteristic CT finding in thyroid orbitopathy is enlargement of the extraocular muscles with normal tendinous insertions onto the globe. Other findings include proptosis and anterior prolapse of the orbital septum due to excessive orbital fat and muscle swelling. See Figure 4. Patients at risk for developing optic neuropathy may also have severe apical crowding, a dilated superior ophthalmic vein, and anterior displacement of the lacrimal gland. Of these, apical crowding is the most sensitive indicator for the presence of optic neuropathy. The CT scan should be done in the coronal plane to assess the enlargement of the extraocular muscles at the apex because axial sections can sometimes be misleading. Thyroid eye disease. Orbital CT, enlarged muscle belly, tendon normal. Magnetic resonance imaging. MRI using 1.5 Tesla units and orbital surface coils provides optimal spatial resolution of the orbit. 34 MRI may also be useful in distinguishing between active and inactive disease. The changing intensities between T1 and T2 weighted images may differentiate the active edematous from the inactive fibrotic muscle changes. Extraocular muscles that have acute inflammation have longer T2 times owing to the higher water content. Because acute inflammatory disease responds better to radiation therapy than chronic fibrosis, the information gained from MRI may theoretically be helpful in choosing patients for radiation therapy. Systemic thyroid disease. There are no good recent studies of the natural history of untreated hyperthyroidism, but based on older reports, Wilson 56 determined that about one-third of patients spontaneously improve, one-third remain chronically hyperthyroid, and one-third progress to thyroid storm and occasionally death. Because it is not possible to predict which patients will spontaneously improve, treatment of thyroid dysfunction is recommended. Treatment: acute congestive ophthalmopathy, compressive optic neuropathy, motility disorders, eyelid abnormalities. Treatment: acute congestive orbitopathy. 1. Symptomatic: elevate bedhead, lubricants, lid taping, diuretics. 2. Systemic: A. Normalize thyroid function with or without thyroxine. Patients rendered euthyroid to improve their GO score. 12-step trial in NJ-Med 1992. Antithyroid drugs cause a 10% chance of new or worsening GO. But radioiodine causes a 30% chance of new or worsening GO. Corticosteroids have been used successfully in the treatment of acute congestive orbitopathy. Corticosteroids have been used successfully in the treatment of acute congestive orbitopathy. They are believed to work by altering cell-mediated immune response and diminishing the production of mucopolysaccharides by the orbital fibroblasts. Corticosteroids result in improvement of soft tissue involvement and compressive optic neuropathy, but do not have as much of an effect on diplopia traditionally. A short burst of high-dose corticosteroids has been given, usually in the range of 60 to 120 mg/day of oral prednisone. Improvement in subjective symptoms such as pain and tearing usually occurs first, often as early as 24 to 48 hours, followed by improvement in soft tissue congestion and muscle function over a period of days to weeks. Steroid therapy, prednisone or prednisolone. This is standard treatment, but there are frequent side effects. No response in 35% of patients, and anyway the response is only partial. High-dose steroids given early in the disease when muscle swelling occurs does not necessarily limit the long-term course of the disease. If there is no response to high-dose steroids in the first 3 weeks, they should be rapidly reduced. Prednisolone plus orbital radiotherapy has slightly more effect than either alone. Use high-dose pulsed methylprednisolone if urgent optic nerve decompression is required. This is more effective than oral treatment, but it is expensive and not justified in most cases of TED. Radiation therapy. During the past few years, radiation therapy has re-emerged as a useful form of treatment of severe orbitopathy. The rationale for the use of radiation therapy is reduction or elimination of the pathogenic orbital lymphocytes, which are markedly radiosensitive. It is also thought that the glycosaminoglycan production by fibroblasts is reduced, thereby reducing orbital edema, orbital tension, and conjunctival injection. Although congestive findings improve most consistently, significant improvement in proptosis and extraocular muscle function has been reported. Like corticosteroids, radiation therapy is most effective within the first year, when significant fibrotic changes have not yet occurred. Moritz and Associates, 135, however, suggest that periods of active orbital inflammation within the long natural history of thyroid orbitopathy would benefit from corticosteroids or radiation therapy. Radiotherapy. Retrobulbar radiotherapy. Trial of prednisone versus radiotherapy showed no difference in clinical improvement, about 50%. The patients all tolerated retrobulbar radiotherapy better than steroids. Consider if steroid maintenance greater than 25 mg/day. Best effect in acute disease. Do not irradiate patients with diabetes mellitus as they are more susceptible to radiation. Retinopathy. 2000 rad/10 days, effect starts at 4 weeks, maximal 4 months. Compressive optic neuropathy. Compressive optic neuropathy can cause permanent visual loss. The treatment possibilities include high doses of corticosteroids, irradiation, and orbital decompression. Some patients require only one of these modalities, while other patients need combined therapies. Compressive optic neuropathy. As in the treatment of acute congestive thyroid orbitopathy, radiation therapy is becoming increasingly popular. A retrospective series of 84 patients with compressive optic neuropathy treated with either corticosteroids or radiation therapy supports mounting evidence that radiation therapy may be safer and more effective than corticosteroids. Radiation therapy, however, must be administered in fractionated doses, which delays its beneficial effect. For this reason, if visual dysfunction progresses while the patient is on corticosteroids, surgical decompression is usually recommended if the patient is a surgical candidate. Orbital decompression. Orbital decompression is indicated for compressive optic neuropathy when there has been failure of or contraindication for corticosteroids or radiation therapy, or if corticosteroid dependence has developed with intolerable side effects. Other indications include excessive proptosis with exposure keratitis and corneal ulceration, pain relief, and cosmesis for disfiguring exophthalmos. Orbital decompression may also be indicated as a preliminary procedure to extraocular muscle surgery on a patient with sufficient proptosis to suggest that decompression might ultimately be required. Orbital decompression. A variety of approaches may be used, each with its own advantages and associated complications. The transorbital, via fornix or eyelid, approach to inferior and medial wall decompression is the most common approach used by ophthalmologists. The addition of a lateral wall advancement has the advantage of both further increasing the orbital volume and simultaneously improving upper eyelid retraction. This is the technique we prefer, orbital decompression. Subciliary approach. Inferior and medial wall, 6 mm proptosis. Remove bone to posterior wall maxillary sinus, 5 mm more posterior on medial wall, avoid ioneurovascular bundle, and the anterior and posterior ethmoidal arteries. Incise periosteum in AP direction posteriorly and circumferentially anteriorly. Complications: visual loss, a pattern ET, motility disorders. A major source of morbidity in thyroid orbitopathy, and the most frequent problem associated with orbital decompression surgery, has been strabismus. In patients with relatively minimal degrees of ocular misalignment, diplopia can be avoided with a compensatory head posture, Fresnel-plastic Presson prisms, or temporary occlusion. Unfortunately, there is significant image degradation as larger prisms are used, limiting their efficacy. If there is marked asymmetry in ocular deviation in different fields of gaze, prisms are also less effective. In some cases during the inflammatory period, use of intramuscular botulinum toxin has shown some efficacy. Extraocular muscle surgery should be postponed until the muscles are no longer inflamed and the deviation has remained stable for at least 6 months. Surgery: strabismus surgery, aim for maximal area of fusion without abnormal head posture. IR recession on adjustable plus/contra SR recession. 3. Eyelid surgery. Upper lid retraction, Muller's tenotomy, less than 2 mm, levator's myotomy or recession on hangback sutures, levator tenotomy plus/horns. Lower lid retraction, usually needs a spacer from donor's sclera, lid retraction x2 equals amount of sclera required. 4. Blepharoplasty for excess skin and fat. Ideally, treatment combines a multidisciplinary coherent approach such as combined radiotherapy and immunosuppression trial,